in terms of general fund state new investments, specifically for substance use disorder services. The primary investments in SUD services that were expansions were opioid settlement dollars, which by obligation have to be spent on this topic and this cause. And so when you think about this notion that budgets are moral documents and budgets are reflection and statement of values, the state did not actually elect, even though it was the year of fentanyl in the middle of this crisis, we actually did not elect to spend a significant amount of our general fund state dollars, which again is our most flexible resources, to this issue. And the reason that I find that, and I'm sure I have folks who probably agree in this meeting, frustrating and painful, is because turns out we largely know what to do to address substance use disorder, fentanyl, right? And we haven't had it completely figured out, but we know that certain things work. We know that access to medications work, and yet we still have darn near 2/3 of our counties that have no opioid treatment program, no access to methadone. We know that access to low barrier buprenorphine works. We know that health hubs work, but are we funding those in terms of the number that actually applied for the RFP, which was like 12 or 15, and we funded a couple. We know that recovery housing works, but the demand for recovery housing in the state outpaces supply by a factor of 3 to 1, and we have a number of counties that have zero recovery housing. Just another example, I was meeting recently with the Department of Corrections, and the Department of Corrections has a population that they refer to, I don't love the name because it's fairly pejorative, but they call them their violator population. And what this refers to is individuals who are on community custody, DOC community custody, which is about 13,000 roughly individuals in the state. And they have violated a condition of their community custody, and they are taken into custody. And for a variety of reasons, mostly because the bed rate that DOC will pay is quite low, many of the jails won't accept those contracts. And so what's happening is DOC is actually housing these violators who are generally there for a maximum of 15 days, often less. They're housing them in our prisons. So Purdy for women, and then often all the way in Monroe for males, regardless of where they came from. And so they are not actually, while DOC is now inducing individuals with opioid use disorder who have a planned release, right? So they've been in total confinement and they have an ERD or an earned release date. They're offering them an opportunity for induction onto MOUD. But this violator population, who again are people in the community, a huge percentage of whom have substance use disorder, they're being reincarcerated temporarily, and they're not offering MOUD to the violator population at all due to cost currently. And so it just seems like there's so many obvious low-hanging fruit solutions, and the state's just not doing it. We're just not paying for them. And that was the case prior to us having a budget problem. And so that becomes even more true now. And ever the optimist that I am, I do have some proposed solutions to address that. It is extremely unlikely that we're going to get general fund state dollars. Again, those are flexible dollars that can be spent on anything, K-12 education, Department of Corrections, natural resources. It's unlikely that we're going to get that kind of money for our stuff. Our stuff is expensive, number one, and number two, there is no money this year. And so the only way that we're going to be able to see investments in our area, which are clearly sorely needed, is if we come up with our own money. And so I am going to be introducing, it's likely going to be actually just one bill that has multiple different components in it, but mechanisms to raise revenue sort of from substance-related industries that would then be targeted for the types of programs and others that I just mentioned. One other program I neglected to mention that I think is another program where it's an obvious low-hanging fruit solution is the Recovery Navigator program, which again, statewide expansion of LEAD. We have many, if not most, of our R&P jurisdictions, which SURSAC's heard a lot about that program and its successes, a lot of them are at capacity. And so it would be now that we're staffed up, it would be relatively easy to kind of turn on the spigot and increase appropriations and staffing to those programs. Again, that costs money, general fund state resources primarily. So the legislation that I intend to introduce related to revenue currently has got three parts. Part one was a piece of legislation that was actually introduced by former Representative Kilduff in 2020. It is called an opioid impact fee, and this levies a per milligram morphine equivalent fee on opioid manufacturers. So think like the Purdue Pharmas of the world for opioids that are sold in the state of Washington. And that would generate pretty significant money. I got to look at the most recent Department of Revenue estimates, but it's somewhere around $30 million annually, so a non-insignificant sum. And then again, when you think about the pharmaceutical industry, there's sort of three parts in an oversimplified world of the distribution. There's the manufacturer, which the opioid impact fee would target. And then you have the sort of middlemen, which are the pharmaceutical warehouse distributors. And then you have pharmacies on the end. The second piece of the bill would target those middlemen, who you may be familiar with because they are actually currently paying out the nose to Washington State for their role in perpetuating the opioid epidemic in this state. There are three of them that are Fortune 500 companies. I think they're actually Fortune 50 companies that make up 90% of the market for pharmaceutical warehouse distributors. Those are Cardinal Health, AmerisourceBergen, and McKesson. Those companies are all, again, are paying us for their role in fueling the opioid epidemic. And those companies were all given a tax break or a tax loophole or a tax preference, whatever you want to call it, about 20 years ago. And I'll spare you the details, but basically at the time, there was an economic reason to actually create that tax break because there were economic disincentives for those companies to have their warehouses located in Washington State. And because we want the jobs, we would like their warehouses here. So we created this tax preference to ensure the warehouses would set up shop here in Washington. All well and good. About roughly 10 years later, the business case that led to the creation of that tax break was resolved. And what I mean by that is the issue was fixed. The playing field was leveled such that there was no longer any economic disincentive to establish in Washington State, which there previously had been, and the tax break was to equalize that. They all became equal without the tax break. However, because those companies have, frankly, a lot of hired guns in Olympia, a lot of lobbyists and lobbying pressure, they have been able to retain that tax break, even though there's no longer any economic justification for it. And it's just again, it's similar to the opioid impact fee, roughly about $30 million giveaway to some of the richest companies in the world every year of Washington State dollars. So, those two would be part of it. And then finally, the last piece, and I should say that the pharmaceutical warehouse distributor bill, I've run that bill a couple times before with no success, in large part because of the powerful lobbying interests that I'm up against. And then finally, the last piece has to do with liquor license fees. So some years back, actually during the time of COVID, I had asked our nonpartisan legislative staff to take a look at all the different types of liquor license fees in the state of Washington. And it turns out there's nearly 60 different types of liquor licenses, everything from like a distillery license to a wine distributor license to a license for a snack bar to sell alcohol. And there's obviously larger and smaller numbers of licensees depending, bars and taverns, things like that. And I asked staff to look at what are the different license types, what is the fee currently, and when was that fee last updated? And it turns out that many of the fees, if not most of the fees, have not been updated since the 80s or 90s. To give you a couple examples, the current distillery license is $2,000. This is obviously distillery for hard alcohol, and that fee was established if basic inflationary adjustment, that would be about $7,500 in 2025 dollars. by a similar token, the wine, there's a big business for wine and beer distribution. They occupy kind of the middleman space in the movement of alcohol in the state, similar to the middlemen I just described for pharmaceutical warehouses. And they have a fee to become a beer or a wine distributor. It's $600, and it was last established. It was last updated in 1997 when I was in fourth grade. So again, if you were to look at just basic inflationary adjustments across the board for those fees, you would generate some pretty significant revenue. I've got to figure out the exact amount is a little bit complicated because it depends on how many licensees are in a given category and how long ago that fee was updated will be a derivative of what the uptick is. But it's significant. So if you take all those things together, we're getting close to 100 million a year, probably not quite, but that's not chump change. That's not insignificant. That's getting close to a couple hundred per biennium. So that would be very, 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 very significant. I mean, that would be a massive investment for these types of services. And then the idea being that funding would go into an account, and that account would be limited in its distribution for services such as the type of things that SURSAC has proposed. Some of the things that SURSAC has proposed haven't been funded. Just one example that comes to mind: family law assistance for parents with substance use disorder. That wasn't funded. That's expensive. Most of the stuff actually that we care about has a significant general fund fiscal hit, and so that's kind of my proposal there, and happy to talk a bit about some policy stuff specifically. But the way I see it, for our issues, our fight is primarily monetary. It's primarily with the budget, because again, we largely know what to do, and there are a lot of low-hanging fruit solutions that we could scale if we had the funding and if we had the political will to do it. And that's where all of you come in, is helping create that political will, including a political will to take votes that would be perceived as penalizing the industries that I just mentioned, the alcohol industry and the pharmaceutical industry. So let me just pause there and see if there's any questions about budget, revenue, that sort of thing. And then happy to talk a little bit about policy bills. And I also want to be mindful of time. I know we are a little bit ahead of time, but still.
Questions for Rep. Davis? Kevin, go ahead.
Thank you, Rep. Davis. You've been one of the voices on SURSAC that truly you're dialed in. I mean, this is your bailiwick by far. But having sat on this committee for a number of years now, I'd just like to know, because your quote was, "We know what works." Okay. And as we look at the numbers, the data, I'd like to know, where are the substance use disorder, the impacts, where are they reducing in the state of Washington? Because obviously, if we're going to be asking for more money, then we have to be able to show that these programs are reducing the number of fentanyl deaths, the number of people that are impacted by substance use disorder. And I'd like to know where those numbers reside, because empirically, I'm not seeing these reductions. And, if we look nationwide, where there's like a no kidding reduction in budgets for state governments, I'd like to know where these numbers are reducing based on the increase in monies being spent specifically towards SUD programs. Because if we know what works, then we need to put those dollars somewhere that do reduce these figures. Thank you.
Yeah, that's a great question, Kevin. So I think my initial gut reaction is that, where we have the data is not usually sort of geographic. So we can't point to, massive reductions in, recidivism or opioid use, opioid overdoses or things of that nature, opioid overdose deaths. in, the city of Shoreline, let's say, where I represent. We don't have that. What we do have is data for individuals who are participating in some sort of bounded system or a program. And so that's when I talk about we know what works. I'm talking about data derived from specific programs like LEAD/Recovery Navigator program, wildly effective, not scaled. I'm talking, where again we see reduced recidivism, improved quality of life outcomes, decreased emergency department utilization. Another program, I don't think we have data yet on it, but hopefully it will be collected, that the state launched relatively recently, which is Scala Northwest, which is the state's program to induce individuals who have opioid use disorder who present to an emergency department on MOUD. And the data suggests that that's roughly about a third of Washingtonians with opioid use disorder will present to one of our state's 100 or so hospitals every year. And are we giving them opportunities to induce on medication? So programs like that. Other programs that show efficacy. Another program, co-lead, which is basically rapid rehousing for individuals experiencing chronic homelessness, individuals coming out of encampments in single room settings, aka like former motels or nursing facilities, that type of facility, and then actually providing that wraparound case management. Ton of success out of that program. So I would say it's kind of pockets of excellence, and it would be a matter of scaling programs like that. And the hope would be, right now, still to this day in 2025, to be able to kind of successfully walk a treatment and recovery pathway in this state, it's like, an act of God plus an act of Congress to be able to get that to work. I mean, the systems just don't bend and flex and respond to people. People have to contort themselves and, fit through this eye of the needle in order to get care. And that's still largely true. Like for everything to perfectly line up, it's like a moonshot. And so the programs where that do by design line everything up, which is largely those intensive case management programs, tend to be very effective. But it's an issue of scale. And we do have really good data, at least on LEAD, and hopefully soon on the others.
Thank you. Malika.
Hi, Rep Davis. Thank you for your creativity. And, this bill is something that I largely think it could be useful. My only concern, and I've brought this up before, is have we looked at, from the storage perspective, how much of that, specifically with McKesson, is syringe service plans, supplies for the state? Because it was about 20 years ago that work, started, as far as like, storage space and things like that. So I'm just wondering, would that impact in that particular area? Will it impact the people that we're trying to help in a negative way by limiting space for storage of supplies for other state programming?
So you're worried about like literally the physical storage space within a warehouse?
Yeah, because from my understanding of what you said, we'd be taxing that capacity. And am I correct in
No.
Oh,
No,
okay.
sorry, I probably explained it poorly. So we're not taxing the capacity, we're taxing the sales. So we're taxing the business volume that they're doing in pharmaceuticals, regardless of where that warehouse is physically located, if it's within Washington borders or not. If they are operating as a pharmaceutical middleman in the state of Washington, we're taxing. And again, we're not actually increasing taxes. We're literally just removing this absurd tax break that has no economic justification. That's just like a $30 million giveaway to these Fortune 50 companies.
Okay, thank you.
Sure. And I will just mention on the other bill, the opioid impact fee bill, MOUD is exempted. So it's an opioid impact fee on non-MOUD opioids.
Okay, thank you.
All right, thank you. Amber.
Hey guys, I just wanted to give a little bit of data for that first person just from my area in Walla Walla as to how some of these dollars are impacting folks. In October, there were 302 uses of naloxone, which was equal to what we observed in the entire year of 2021. And I also wanted to say that as of December 7th, we had surpassed 1,700 instances of lay people using our naloxone to try to reverse an overdose this year, which is nearly twice the number of last year of 933. And that's out of 9,600 kits distributed. It's like a 17.5% use rate. So those dollars are going to what works. And we know that naloxone distribution is something that works. At least in my community, it works very well. There's been a lot of lives saved and a lot of naloxone distributed. So I just wanted to throw it out there.
Thank you, Amber. Caleb.
Good morning. I'm also piggybacking on what Amber just said. Blue Mountain Heart to Heart is one of the 5 Washington State Health Engagement Hubs. SURSAC recommended 39 of them. And in terms of numbers, the chat's not working for me, so I will have to send articles in another way. But the Seattle-King County buprenorphine pathways that started in 2017, we have published research on the effectiveness of that. And the Medications First project, which we replicated in 6 additional sites, showing a 2/3 mortality reduction. We have data that is also out there. And I think the point is it's really about scale. We have about an 80% treatment gap. So let me say it another way. About 20% of people are getting life-saving treatment medications. They should be seeing a 50% mortality reduction. That's wonderful, but those are proportions of proportions. You need to get to total scale, total saturation of the entire population to start seeing large-scale mortality impact. So we know what works. It's really a matter of taking it to scale. So when Rep. Davis says that that's correct, and you're welcome to look on learnaboutTreatment.org, and we can point you to some of that research. So I'm happy to share that forward, but the SURSAC recommendations were based on what works.
All right. Thank you. Rep. Davis, anything else you'd like to add?
Sure, and thank you to the phone a friend. I like when people answer the questions for me. It's very helpful. Yeah, I mean, I'll mention a couple other things that I, am aspiring to do policy-wise. It's always a question of bandwidth, and at least in the House, we only have 1 staff person. I'm a single legislator, which is why it's helpful to get for us to continue to build more allegiances and alliances with other lawmakers, because just my capacity to I never have enough bandwidth to run all the SUD bills that I'd like to in a given session, but things that I'd like to get done. So one issue pertains to recovery residences. So when I was a freshman baby lawmaker in 2019, my first year, I had a piece of legislation, House Bill 1528, that created the state's registry for recovery residences, as well as provided funding for the accrediting agency, which is the Washington Alliance for Quality Recovery Residences, or Walker. And what that was primarily trying to address was the fact that at the time, recovery housing was just sort of this like Wild West industry where anyone could hang a shingle and declare thyself a recovery residence. And, we have very vulnerable people, young adults coming in to live in these locations, and we're being preyed upon financially, sexually, in other ways. And so, but at the time in 2019, I couldn't just sort of immediately say, okay, like everything has to be a certified recovery residence, because we had like very, very, very few certified in the whole state at the time, like less than a half a dozen. And if I had done that, nobody would have had anywhere to live. And so what I did put in the bill was, it said starting January 1st of 2023, it put a prohibition on referrals. So it prevented, behavioral health agencies from referring an individual to a non-certified recovery residence. And that helped. There was people procrastinate, myself included. And so as a result, there was this like massive influx of applications to certify recovery residences prior to that impending deadline. HCA has done a great job, as have different counties, of tying funding. So if you're going to have like a housing voucher that goes to, for people with SUD and recovery housing, it best to be an accredited residence. That being said, I don't feel like that went far enough. I continue to hear reports, not infrequently, of predatory behavior toward individuals in early recovery and their families, actually, often financial predatory behavior toward the families, and just continued unsavory behavior in quote unquote recovery residences that are still operating lawfully, even though there's that referral prohibition. So trying to think about what would be the next step there. I've also, would like to address an issue related to prior authorization for particular types of buprenorphine. So right now, most commercial, so for Medicaid, right, which is about only 1/4 of Washingtonians are on Medicaid. A disproportionate number of people with opioid use disorder have Medicaid, but still, there are plenty of people with OUD that do not have Medicaid. And for those individuals seeking long-acting injectable buprenorphine, so Sublocade, Brixadi, things like that, most commercial insurance carriers still require prior authorization, which is, some processing paperwork prior to authorizing the dispensing of that medication. Why is that a problem? That's a problem because of window of willingness. So what if you have somebody who had a medical event associated with their OUD and they are discharging from a medical surgical floor, or they are in the emergency department, and you have them right then, opportunity for them to make a choice to be induced on an injection, and then obviously that helps because they don't have to make 3 choices today to dissolve sublingual strips to choose recovery over and over again. They've got that medication on board. But if you require prior authorization, you can't do it in the moment. And that's just a huge missed opportunity. I had worked with Senator Dinger on a bill last year, Senate Bill 6228, that addressed there was a problem with hospitals actually getting paid for long-acting injectable bupe, and so they just weren't doing it, and that got fixed. So waiving the prior auth, and then another issue with prior auth has to do with the buprenorphine mono product, so which is folks more familiar with, known as Subutex, typically given to pregnant individuals, but basically just like SSRIs in the antidepressant world, people's biochemistry is different. Some people respond differently. Some individuals don't do well on Suboxone or Brixadi or Sublocade, where it's the formulation of buprenorphine plus naloxone. And so they do better on the buprenorphine mono product, aka straight buprenorphine. This just got fixed by HCA. Hat tip to Dr. Patinos. This just got fixed for Medicaid patients like 2 months ago in October, I think. But that is still a problem for commercially insured patients. The commercial carriers will deny the bupe mono product unless the patient has had an anaphylactic reaction. As far as I'm concerned, if they're going to take the bupe mono product and not the combined product because of whatever, it doesn't make them feel well, they're nauseous, etc., side effects, that's enough. So that would be another issue that I'd like to address. I've also got a piece of legislation related to peers. So I am just a massive believer in the gospel of peer support, and believe it is the solution, maybe not to everything, but to many things. And I still continue to believe we're underutilizing peer services. And so I've got a piece of legislation that would do quite a number of things. The first thing it would do, which is important, I made a mistake in naming so we had legislation a couple years ago that I worked on with Senator Randall that actually created a true legitimate healthcare profession for peers, which actually under current law, it was a certificate, a piece of paper, but not a license. So peers will be they'll be certificated in the same way that paramedics are, actually starting in July of this year. However, I in an error of just foresight. I didn't think about the acronym for that profession. I called them certified peer specialists, and that is not a good acronym for individuals that have a prior history with the child welfare system. So going to change the name to certified peer support specialists, CPSS. But the bill actually does a lot of other things that I think are important and interesting. As introduced, subject to, stakeholder discussion, but as introduced, there's a conversation about the Healthcare Authority reprocuring Medicaid. So right now, folks are probably aware we got the 5 Medicaid managed care organizations that operate in the state of Washington, and different regions. There was procurement for different regions, and the MCOs bid to serve a given region. So there's conversation about reprocurement, and what the bill would do is it require the Healthcare Authority to require potential bidders for that reprocurement. So Medicaid managed care organizations would be required to provide an analysis of access to peer services within their region, and they'd have to specifically delineate access to mental health peers, SUD peers, youth and family peers. And then they would have to, the accessibility of peer services within an MCO's network would be given great weight in the determination regarding Medicaid reprocurement. Would also require HCA to develop, to contract with an outside entity to do a whole bunch of things. A lot of this is probably boring and it has to do with billing, but there's sort of a method to my madness. And what I'm getting at here is in some cases, because we have this budget problem and we have limited general fund state dollars, and because, as Caleb said, it's a matter of scale and we aren't scaling our best ideas. One of the things we can do when we have limited general fund state is making sure we're maximizing insurance billing for the existing services so that the limited general fund state dollars we do have are geared toward individuals who are underinsured, uninsured, or for non-insurance reimbursable services. So basically it would direct HCA to come up with a contract to with an entity to develop innovative proposals to look at low barrier, cost-effective opportunities for community-based agencies, including peer-run agencies and non-behavioral health agencies to bill for peer services. We have a lot of by and for organizations, small organizations that are doing peer services that are not billing eligible currently. But if you looked at what they're actually doing, it's healthcare services, it's peer services. And then also developing innovative proposals similarly for low barrier, cost-effective opportunities for billing health insurance for models that we use the state general fund for. So things like LEAD, the Recovery Navigator Program, the Arrest and Jail Alternatives Program, and then the Homeless Outreach Stabilization Transition Program, or HOST, which those programs are entirely funded with general fund state right now with 0 health insurance participation. So looking at that. Also providing technical assistance. So I mentioned that peers are going to be this new healthcare profession starting in July. What that means is that for the first time, primary care, urgent care, and hospitals can actually bill for peer services because they're a quote unquote legitimate profession. I don't mean to suggest they weren't legitimate before, but in the eyes of Title 18, the big book of healthcare professions, they're going to be in there. But just because it's now going to be possible for primary care or urgent care or emergency departments or medical surgical floors to bill for peers doesn't mean it's just going to magically happen. And so actually doing that targeted support to actually make that kind of bear fruit and to help primary care figure out the clinical workflows and the billing, help emergency departments and medical surgical floors figure that out. Also looking at mechanisms. So I think there's been some conversation about this in SURSAC. Right now, under RCW 7124-649, this was a 2019 bill. We created the model for mental health peer respites, but this would look at the creation of a substance use disorder peer respite, what that would look like, how it would be billed, that sort of thing. And then finally, the last piece has to do with kind of trying to marry my behavioral health work with some other work that I do related to gender-based violence. So there's a very substantial overlap between individuals who are victims of domestic violence, sexual assault, and human trafficking, who either already had or develop as a result of the trauma, substance use, or mental health challenges. We also have a massive issue in the state with funding victim services. We're facing a $51 million shortfall across our victim services agencies. And so and it turns out if you actually look at who works in victim services agencies, in human trafficking, it's primarily human trafficking survivors doing that work. In domestic violence, it's most DV advocates are survivors themselves. So it's effectively peer work, but it's not being called that. And it's not being billed as such. So this would direct the development of some certificate programs for a person who is a peer, qualifies to be a peer in behavioral health, but also is a DV survivor or also a sexual assault survivor who would then receive training to do that victim services work and actually bill insurance for it. So just trying to get a little creative, a little, I don't want to say sneaky, but just trying to maximize the billing because of the dollars that we do not have. So I think I'll pause there. Happy to take any more questions or happy to stop talking.
Thank you. We have time for maybe 1 or 2 questions. Anybody have any more questions for Rep. Davis? Addie, go ahead.
Thanks. Thank you for your work on this. I will say I'm an opioid use disorder treatment nurse at Harborview Medical Center, and that PA work would be huge for many treatment providers across the state. So appreciate that. And then just this is going to show my naivete around the legislative process, but how can we become informed about these bills so that we can, as citizens, advocate for them, particularly the revenue?
Yeah, that's a great question. One immediate thought that comes to mind. So before I became a legislator, before I accidentally got elected, I used to be an advocate. So I used to be tracking the legislature and trying to testify on bills. And in general, the best way to get engaged is to work with some sort of advocacy organization that's topical to the areas of interest. NAMI does work on the mental health space. There's a lot of organizations that do work on behalf of formerly incarcerated individuals. In the addiction recovery world, the primary advocacy organization is called the Washington Recovery Alliance. Full disclosure, I do work for them part-time, not on their legislative advocacy work, obviously. But they, as an organization, are working on the revenue piece. They also have something that they refer to as RAD, which is Recovery Advocacy Day at the state capitol, where they bring individuals such as yourself or people on this call to the capitol. They set up all the meetings for you, bus people down, that kind of thing. And then they provide updates throughout session on the progress of those items. They also do training. So they do training on how to engage and participate, how to testify in a bill, how to talk to your lawmaker, how to ask for their vote, that kind of thing.
All right. Thank you, Rep. Davis. There are a couple of things in the chat. If you can see the chat from Susan says, my only question is how can we support advocate and advocate, for these changes?
Yeah, I would really, it sounds like people always say contact your lawmakers, but literally actually contact your lawmakers. A heartfelt email from a professional, somebody who's a provider or somebody in recovery or a family member that is written to your actual legislators, it still works. Like that still is the recipe. Asking for a meeting with your lawmakers to discuss these things is even better than sending an email. But it's kind of like the form emails, the click stuff, I would say is not super impactful, but the personal, detailed, pointed emails, those are the ones that our legislative systems flag for us that get responses. It's actually annoyingly really hard to find legislators' emails. Actually, they make you try to fill out a form. So I'm going to put something in the chat, which is called the all members roster, which actually lists all legislators and their legislative assistant emails. So I would encourage you to contact your own lawmakers, but also, you can contact committee chairs, budget writers. It really does make a difference. And then also showing up in Olympia too, to meet with folks, or having a Zoom meeting with them too.
Thank you. And Malika, I think that you'll have the last question or comment here. Go ahead.
I just wanted to say thank you to Rep. Davis for sharing that information. And I also wanted to bring up some really key dates for folks if they're interested in participating in advocacy. I'm wearing my Vocal Washington hat now. On Martin Luther King Day, there is going to be the Washington Poverty Network is having an advocacy day. And since it's a day that we all have off too, well, the legislators won't be off, but a lot of us have the day off because it's a federal holiday. There will be a number of folks organizing at the Olympia Center, and then February 6th and February 10th, if you're interested in advocating with impacted people. The 6th is the Washington Recovery Alliance Advocacy Day, and the 10th is the Systems Impacted Individuals Advocacy Day. And if folks want more information, I'll put my email in the chat.
All right, thank you. Tony, I'm going to kick it back to you if you want to add anything and introduce our next guest.
No, just echoing others' appreciation for Representative Davis and spending that time and sharing those updates. A lot of great work happening. And just a reminder, we have in the past and will continue to do so, but sending out as part of the SURSAC Gov delivery announcements, we'll include legislation as it gets introduced that's related to substance use disorder or programming or policies for individuals who use drugs or that might impact individuals who use drugs. So, Addie and others who asked about bill numbers or kind of, how to stay updated on this, we'll definitely do our best to share those key pieces of legislation as part of our Gov delivery announcements as they come through. And then Malika, if you want to send us any information about those specific advocacy days, we can also include those in the notes for that we send out after this meeting as well. And with that, we're almost right on schedule, a little bit behind, but we're going to transition to some time for Senator Dingra to share some policy and program priorities from the Senate perspective and from the work that she's involved in. So Senator Dingra, I believe I saw that you were on the call, and if you're ready, we can.
Great. Well, good morning, everyone. It is always great to be here with all of you. I'll just start off by saying thanking you for all the work that you all do. I don't think a lot of people outside of this group completely understand and comprehend your passion and your recommendations and where they come from. And I always like to think about journeys of groups before I'm talking to a group and just reflecting back on when this group started, the recommendations that you have made and how many of them have actually been implemented is actually really impressive. I do know we have a long ways to go, but I did want to start with that acknowledgement and gratitude for the work that you've done. I also say I always love going after Representative Davis because she takes care of all the hard questions. She explains all the hard policy and makes my life a lot easier. So thank you, Rep. Davis. She is truly the SUD expert in the legislature, House and Senate. And a lot of the work that I do in the Senate is actually in partnership with her. I don't think there's a single bill that I have worked on relating to SUD that is not a joint effort between the two of us. So I'm always happy to follow her lead and get her brilliant ideas on how to remove barriers in our system. So just know that even though some bills may have my name on it, it is definitely not me. It is this group, it is Rep. Davis and a lot of other advocates that are behind a lot of these policies. So thank you for that. And I'll just start off by repeating some of what Rep. Davis has said, is that we are in a very tough budget year. by state law, we have to have a balanced budget. We have to have a 4-year balanced budget in the state of Washington. And so we are, in essence, looking at a $4 billion deficit. And so this session, we will be taking a look at how we balance this budget for the next 4 years. And, $4 billion sounds, I'm sorry, $12 billion sounds like a lot, and it is. And so I am extremely mindful of what we had done, not we, I guess the legislature, I wasn't there then, during the recession. At that time, they decided to make cuts on the backs of the most vulnerable among us in our communities. And I, for one, am determined that that is not the path we go down again. This was a fight that I took on during COVID, when people's first response was to start cutting the state budget because they weren't sure what was going to happen during COVID. And I don't know if many of you remember or not, but in the Senate, we decided to have a joint committee on economic recovery and decided to really take a look and study what is happening to our economy during COVID, and then have a thoughtful approach on economic recovery. And so even though times are tough and have been tough for the last few years, we in Washington had the best economic recovery in the country. And that's because we decided to take a step back and not simply make cuts that would impact basically the most marginalized among us. I'm committed on making sure we're doing the same thing when it comes to taking a look at our budget. So the first thing we're going to take a look at, and this is something we've started to look at in the Senate, is really figure out what programs are working, what aren't, what are some changes we can make to a current budget that's going to save us money. I can tell you that the thing that I am most passionate about is actually protecting the programs that we know work. And this is where all of you come in. We have already heard about the incredible programs that some of you are involved with. We have to make sure that we're constantly highlighting and saying, save this program because it works. It is much easier to keep something in the budget that we can prove is working, rather than making sure it's something that's on the chopping block. And I can tell you a lot of human services programs, like Rep. Davis mentioned, end up being the ones that are on the chopping block because, frankly, they are some of our most expensive programs. But these are also programs that we know help people the most. So this is my ask of all of you, is really making sure that we're doubling down and supporting the programs that we know that work. My success for this session is going to be if we can pass a budget that saves our current program. So expansion of programs, I don't even know how we would get there. To me, it's not about new programs and expansions of program. It's about protecting what we currently have. And that is what my main focus is going to be this session. I have spoken to Rep. Davis about her incredible ideas about more revenue. I think that is the other thing we have to take a look at, is how we can make sure that we continue the work we've made in the state on progressive revenue and fixing our upside down tax structures. I was extremely impressed by Washingtonians when they refused to let those initiatives pass, those initiatives that actually helped provide resources for our children, for education, and for writing our upside down tax system through the capital gains excise tax. And to me, that is a very powerful message that the people of Washington sent, that they are interested in making expenditures to help the most vulnerable, and they are interested in fixing our tax code. And I think that is something we in the legislature need to build on. So that's what I'm going to say in terms of what next session looks like, what a lot of my priorities are. I am really trying to encourage as many people as possible to really try to work on policies that help reduce barriers, but don't cost a lot of money. I know that's really hard to do because really good ideas, really good programs cost money. But this is the year where if there's cleanup that needs to be done, if there are statutes that need to be modified in order to remove those structural barriers, I think this is what we should be doing. I failed to say, to introduce myself properly, I'm actually the Deputy Majority Leader of the Washington State Senate. I chair the Law and Justice Committee. I sit on Ways and Means. And so a lot of the work that I do is around those arenas. What I've also been doing a lot of work around recently is the 988 implementation, and we continue to take a look at that structure as well. And that work will continue. They have their recommendations coming out. A lot of my other work is around gender-based violence, criminal justice reform, addressing gun violence, taking a look at access around that entire spectrum of care, right? From early intervention all the way to taking a look at the forensic and especially with our jails and prisons. So with that, I'm actually going to stop talking and open it up for some more questions. I'm so glad a lot of those questions were answered by Rep. Davis, but I think we end up learning a lot more when we have the question and answer session. The one other thing I'll mention quickly before we go to the hands is I encourage all of you to follow the work that we do. Go to the ledge.wa.gov website. You can follow legislators' bills. You can follow bills as they go through. You can follow committees. And your voice does matter. When there are public hearings, if you don't want to testify, if you just want to sign in support or not support of a bill, all of that is calculated. We all take a look at it. When you guys send us emails, that is captured. Before I go into any hearing on a bill, I know who has emailed me, whether they're pro or con an issue or a bill, how many on either side. And we know during committee hearings how many people have signed in, pro and con, not testifying, and even testifying. And so please don't think that when you email us, when you call us, when you sign up, that it goes into some Ethernet that no one pays attention to. All of that data is actually making a difference to lawmakers. When I brief bills, I let people know how many people signed in support, how many people testified in support. So all of that matters. And please, please, please do reach out to your legislators and let them know what's important to you, because it's hard trying to figure out how things get done in the legislature, but I can tell you that bills fail not because they're bad ideas. They fail because they don't get enough attention. And so it really is about making sure you create that energy to get your bill or idea to the top. So this is where all of you come in and your advocacy comes in, and it is a powerful voice, and I really hope you all use it. And with that, I'm happy to take any questions.
All right, thank you. Malika, please.
Thank you, Senator Dhingra. And I really appreciate the fact that you brought into focus how the economic disparity and precarity that a lot of people find themselves in is directly related to the issues and the trauma that folks are experiencing that oftentimes contributes to their behavioral health issues. And I'm wondering, so we saw some bills last year that I had the intention of supporting people, and that was clear. However, I think they were a bit misguided. 6109 specifically is one that I'm thinking about, and there's and a lot of the things that were put forward as activities for support for families that are experiencing opioid use disorder have not been implemented yet. And there was only like one-time funding put forward to that. And we're seeing a resurgence this year of folks wanting to, create a further criminal penalty for the end drug user that is not responsible for the drug supply that will greatly impact, families and create that and deepen that generational trauma that was trying to be addressed with like keeping families together and other key legislation. And when we don't have this is a really long question, sorry. Anyway, but then like when we don't have the ability to support people that are experiencing behavioral health issues, and we're looking at cuts and we're looking at, and we've tried to implement LEAD across the state through the Recovery Navigator program. It's uneven. And we know that those will improve stuff, things, but what do you think the likelihood of having, wanting to do one thing, but then ending up doing things that really kind of throw those efforts under the bus? How do we approach that?
Oh my goodness, Malika. I wish I could answer for you. So just in for others, 6109 was a bill with the title called Supporting Children and Families. And what it was trying to do was take a look at the number of children that were actually dying because of exposure to fentanyl. And there were very alarming numbers. And, I remember when the bill sponsor was working on it and they asked me to co-sponsor it. And I said no. And they were fairly shocked because I do so much work around, substance use disorder. And that's what Malika was talking about, is this balancing, right? How do you protect children who might be exposed to fentanyl without breaking up families and criminalizing the parents? Like, how do you move forward in ensuring that children are taken care of while coming up with a trauma-informed process of doing it? And it's really, really hard balancing a lot of these different things. And, these are struggles that we always have in the legislature. I know the House is doing it, the Senate does it too. We have put in process equity lens when it comes to analyzing any bill. So we really take a look at who is being impacted and what manner are they being impacted. Is there a racial component to it, an economic component to it, and really try to make sure that we're trying not to do harm and really are trying to pass legislation that's true to, and I'm going to be very partisan here, I apologize, to democratic values of putting people first and uplifting people. And it is a challenge. It is a real challenge because many times there are competing interests. This is where the input comes in because the bill as it was introduced, and I'm just going to use that one as an example, is not something that I could support. But over the course of the session, it was changed. It was amended to get to a better place. And that is, in essence, the legislative process. And so, we've talked about supporting bills and having your voices heard on those bills. And I would say even the reverse is true. If there are bills that are introduced with good intentions but have negative consequences, that's also a time to really say, hey, have you thought about X, Y, and Z? And how can we mitigate that? How can we make it address those harms and still try to get to the underlying effort on the work that people are trying to do? So it is a balancing act, but the first thing is you have to be aware of what those negative consequences are. That's again where all of your advocates come in. But please know that even in the legislature, both in the House and the Senate, we are trying to make sure we have an equity lens to these bills so that we are able to catch unforeseen negative consequences. But passing legislation, you're never going to get it right the first time. It's actually very rare for something to be perfect the first time, other than Rep. Davis's and my bills, of course. They always need to be tweaked and changed because implementation is completely different than passing the first bill. So even when a bill passes, you have to make sure implementation is going in the manner in which it's intended. And if it's not, that's when we come back and tweak it. And so that's something else for this session as well. The bills that we passed last session, if there are tweaks that need to happen, this is a good session to do that on because they're not new programs, but really trying to fix the ones that we have passed or the ones that may have not been implemented, but are maybe not, the rulemaking isn't going in the manner in which it was intended. So there are opportunities to make sure that we fix mistakes or unintended consequences. So I hope I'm able to get there, Malika, but it is a real struggle to really do that balance on making sure you're doing the right thing in terms of everyone involved.
Thank you, Senator Dingrat. It just feels like though we're in this, like, as both you and Rep. Davis have mentioned, that we're on the precipice of making more cuts on the backs of the most vulnerable. And as a person who did outreach work directly with the community during the first economic recession in 2008, and also when heroin really started to hit the streets hard, and frankly, there was fentanyl in that too at that time, it was so harrowing. I mean, those were also some of the times that as a syringe coordinator, like syringe service program coordinator, we did not have enough money to meet the demand. Like we literally had to go out into the community. And that was as a public entity You know, the funding was just not there. And I am very fearful for how we are going to shoot ourselves in the foot if we make cuts to the things that we know can make a difference. They are making a difference, but they are nowhere near the scale that we need them, because it's not just programmatic change, it is systemic change that will help across the whole continuum, from law enforcement to defense to prosecution. You know, when we look at having a full actual continuum of response, we are beginning to build that out. And LEAD is frankly, and I don't just say that because I work with or like teach the model, like we can see glimmers of this coming into being where we're actually able to have responsive networks across our whole entire state. I would just hate to see it fall apart. So I
Yeah.
know you share those beliefs, so I'm just throwing that out there though.
Yes, and thank you for that. And I think we need you speaking to more people about that. I will also say we are a different legislature from where we were years ago. I do think people are more aware of the consequences of their decision, especially again during COVID. You know, I had very honest conversations about dynamic budgets versus static budgets, right? And this is where a lot of the prevention work comes in, right? They're dynamic budgets where when you invest in prevention work, when you invest in early intervention, when you get people the help they need so they're successful, it pays dividends down the road. But our budget, because it's a static budget, doesn't account for that. And so during COVID, I think the Ways and Means Committee was so sick and tired of me saying it, but I would constantly say that if we make cuts in these programs that enable people to be successful, we're going to shoot ourselves, like you said, Malika, in the foot down the road, because you're going to see more people needing more expensive care because we weren't able to get them out of either the cycle of poverty or mental health or substance use disorder. And I think a lot of the reasons why we had that economic recovery during COVID was because we didn't make cuts for those programs. And I think those are the conversations all of us need to continue to have with everyone, is that when we help people be successful, they actually become taxpayers and pay taxes, increasing our economy. And so to me, you know, that's always what I talk about, is that even though we don't have a dynamic budget, we have to think of programs in terms of that. And so I know we have quite a few champions in the legislature who will be fighting for these programs. And so I want to be realistic, but I'm also optimistic, and I do have faith in my fellow legislators that I think we will navigate this successfully. And like I said, to me, success really means that we are protecting the programs that are already in play. I am not optimistic enough to talk about expansion, even if we do a lot of the revenue generation. I think that's going to help us maintain the programming. And that's what me and a lot of other legislators will be fighting for. But your voices and your messaging around this is going to be critical. And I've spoken to a lot of advocacy groups because I also do a lot of work around poverty reduction. And that's what I told them, is that the messaging has to be very, very clear. We're not going to balance the budgets on the backs of the most marginalized people. Like that just cannot happen in this state.
All right, thank you. I don't see any other committee members hands up for Senator Dingler.
I see
Well, but
Carlene.
I see Carlene. Yes, so let's go ahead and take that from Carlene. And question or comment, please.
Yeah, I appreciate it. This is Carlene Johnson, the Washington State government reporter with the Center Square. And as a coincidence, I actually interviewed Representative Travis Couture this morning on a different piece of legislation, but he did speak to his attempt during this session with another bill concerning protecting children in homes, specifically where fentanyl is used. And he did mention Senator Dhingra. I'm pretty sure, I mean, he didn't mention you by name, but I'm guessing it is you that he was saying, you know, I've worked with folks across the aisle to kind of tweak this bill from last year. Believe I've got enough support to at least get a hearing on it this year. And you just referenced that, Senator Dhingra, so thank you. But can you explain specifically for me what it is that's been tweaked in this bill that now at least leads you to say, you know, we should give this a hearing and potentially, consider this a little bit more in protecting kids exposed in homes with biological parents using fentanyl. And I do have a follow-up question, but which will be very short, but if you could speak to that, I'd appreciate it. Thank you.
Yeah, the bill that Malika and I referenced, 6109, was sponsored by Claire Wilson, and it passed the legislature last year, and it was signed into law. So I'm not quite sure what new bill you're referring to. I would have to read it, but the one that Malika and I referenced is current law.
Okay.
It's
yeah,
effective June 6, 2024.
Okay, I don't have the bill number in front of me either. I apologize, but
yeah, feel free to email me. Happy to follow
yeah,
up
I
with you
will.
on that.
I will. But he did. If you don't mind responding to whether or not you could support the bill, he didn't get I don't think he got a hearing on the bill last year, if I recall. But it was basically kids exposed to fentanyl in homes with biological parents that are addicts exposed to fentanyl. That there'd be at least a temporary, those kids can be removed from the home and the parents can be mandated into treatment, because we've lost, as you know, way too many children in homes with addict parents, because we want to keep parents together, which makes sense. But if it's really about the children, his contention in this bill is then we've got to remove the parents or remove the children from those homes, protect them, and require these parents to prove they're clean and sober before the kids are put back into these homes. Would you support that bill?
Carlene, I would have to know the bill number and read the language. I pay a lot of attention to the words on paper. So if you send me a link, I'm happy to look at it. But without bill language or number, I'm just not able to comment on that.
Okay, a quick follow-up question then, and I don't know if Rep. Davis or Senator Dinger or another member, but given we are in this tough, pickle with the budget, are we basing our legislative priorities on what we know is working, right? Because taxpayer money is more important than ever. So are we requiring the data, pass legislation, being pointed to that as successful in getting people permanently clean and sober? Is that going to be sort of evidence-based in moving forward in protecting programs? As you said, Senator Dingery might not be able to expand because of the budget picture, but maybe protect current programs for taxpayers.
So this is totally sounding like a press conference, but I will take this last
really
question. We are always, I for one, always want to be data-driven and evidence-based in everything we do. And that is not going to change. Always going to be evidence-based, data-driven. You've got to support the programs that work. And this is why the recommendations of this committee are so critical. The recommendations made from the very beginning that SURSAC has done have always, in my opinion, been data-driven, evidence-based, and they become politicized. But when you go where the data takes you and where the evidence takes you, we end up with programming that works. And that's why I'm so proud of the work that LEAD's been doing, along with so many of the other great programs that we have really spent our time and resources and money on. And so, again, I'll end by saying thank you to this committee for the excellent work that you have done and the recommendations that you have made. That even though not all of them have been passed, I have a SURSAC recommendation list that I keep going, and I do refer to it because I want to make sure that eventually we get to a point that we are indeed supporting programs and ideas and bills that are data-driven and evidence-based. And I see Malika's hand up again.
Yep. Go ahead, Malika. Thank you.
As a member of this group, I just want to bring it forward that it's unfortunate that we experienced what we just experienced, somebody coming to this meeting and using really discriminatory language against people that experience SUD. So I'm hoping that we can do a better job of managing the conversation because this wasn't a press conference. This was supposed to be an update from legislators to the group.
Understood. Okay. Thank you, Senator Dingra, for that, and appreciate your comments and your information. I'm going to kick it to Tony here real quick. Tony, would you like to add anything else?
No, just a reminder that we do have time for each agenda item for both the SURSAC comments as well as public comment. And so, I think we allowed time for the SURSAC members to ask any questions or follow up of Senator Dingra. And then when there were no more hands or comments in the chat, we moved to public comment. And then that's when Carlene's question was addressed. So not disagreeing with you, Malika, and others that have commented in the chat about kind of how that transgressed, but just also noting that we do allow time for public comment in the meeting for each agenda item. So sorry that the conversation kind of shifted there, but really want to extend additional thanks to Senator Dingra and Representative Davis for their time and for sharing some of their priorities into the upcoming legislative session. And then also just reminding everyone, and I didn't do a good job of prefacing this, but we did extend the opportunity and the invitation to share time during the SURSAC committee during this meeting with all of the legislative representatives on SURSAC. And so really appreciate Representative Davis and Senator Dingra taking us up on that offer and sharing their time today.
Thank you all so much.
Thank you. Okay, Malika, did you have any more comments?
Yeah, yes, I do. And I would just, we had a practice in the past where we talked about the importance of using people first language and being respectful in our language. And so I would ask that we get back into that practice, because clearly there are people that are joining us in this meeting that are not familiar with that, and that, brought in really disrespectful, and it may not have been intentional. But I would ask that we make an effort to have a culture of respect as far as the language that we are using when we're talking about people.
Thank you. Okay, next on the agenda, we have the review of the mural from December. Michelle and Kelly.
Yes, thank you, Blake. So, sir, are you able to share it? The Excel document? Okay. Well, I mean, just share the screen. I can actually share the screen. I can do it. All right, so I'm gonna share real quick. This one. There we go. All right, so I just sent the link to everybody in the chat, and it will take everybody in the chat is to the SURSAC members only. So this is only viewed by SURSAC members. All of you should have access to the SharePoint. This is the main SharePoint that we use for SURSAC, so you all should have access to that. And so what we did was we took the highest voting from the mural, the highest voting agenda items, and we itemized them. I sent off an email on Friday. It was just a real glance email, just so you guys could know what each of the items are. And I'm also going to go over them right now as well, but they're also so you can refer to later if you like, or now. And also, if you look at the screen, I've put notes in each of them, just so that if you need some background on what this agenda item is. And the whole purpose of this document is so that we can gain your input and feedback on what you would like presented about, for instance, like rural and healthcare, right? So do you want to talk about the limited access to behavioral health services and rural and healthcare? That could be something you put there, right? If you have a proposed presenter, would love to have some proposed presenters. And I already see people putting stuff in there. That's amazing. Thank you so much. And so I'm just going to go over each one of these. Of course, we simplified and only put a couple of sentences for each. There's definitely more information out there about a particular topic, and we can give it to you if you request it. But I'm just going to go over each of these real quick. Yeah, and Tony would like to add something.
No, just just wanted to say, like, I think the spirit of this is to kind of collaborate and partner around how we present these topics to the committee, and specifically honing in, like Kelly said, on what aspects. I think the mural exercise was a great opportunity to kind of just capture and catalog a lot of the different areas that the committee is interested in, especially going into 2025. And we can definitely, within the healthcare authority and partnering with other state agencies, identify various like subtopics or presenters for these overall topics, but just really want to make sure that we're doing it in a way where we're collaborating and coordinating with the committee, and ensuring that there's an opportunity where it's kind of a informed conversation, instead of kind of doing it in a silo. So just wanted to provide that extra like context. And so just be thinking about that when visiting the SharePoint site, and adding any suggestions, subtopics, presenters, and then we can fill in the blanks, as we go forward as well.
Thank you, Tony. And I just seen in the chat a couple people might not have access to it or not able to. I'll after this meeting, I'll send an email with the link, so everybody will make sure to have access and such. And I put the link in a different way, the next link I put, and I thought maybe that might be more accessible. So I'm just going to go over each of the presentations, possible presentations and such.
Yeah, and also you don't have to, like, feel free to unmute, raise your hand now if there's, like, as we go through these topic areas, we can add that, Kelly's got access, Michelle's got access. I'm sure I have access. It might take me a second. But you can just unmute and we can have a conversation about it now as well. So don't feel like we're relegated to just the SharePoint and entering it in that area.
Absolutely, Tony. Yeah, if you put it in the chat as well, we can put it copy and paste directly of what you want into the share document. Raise your hand. Blake, if you see any raised hands, just let me know. And or anybody let me know. And Mike will stop. Thank you. So Roland Healthcare. I shared a little bit already about that. Lead model education series. There we go. LEAD, which formerly stood for Law Enforcement Assisted Diversion, now stands for Let Everyone Advance with Dignity, is a community-based pre-booking diversion model that was originally designed and implemented in Seattle King County. Several of our diversion programs in Washington and nationally are aligned with the LEAD model, which is intended as a suitable alternative to punitive systems for people who are involved in illegal activity as a result of behavioral health needs of poverty. So that is one topic. The next is UW to present on drug checking network and Washington State Patrol Crime Lab data. HCA will coordinate with the University of Washington, present on its drug checking network alongside data from the Washington State Patrol Crime Lab.
And let's pause for a second.
And we're going to pause?
Yeah, just to see if anybody has any questions or if anybody wants to raise their hand or go on mute, and we'll check chat.
Yeah, Malika, go ahead.
I just wanted to add a little quick correction. So law enforcement assisted diversion is also Let Everyone Advance with Dignity. It is both names. It's not formally known as. Just wanted to make that clarification.
Thank you, Malika.
Okay.
Caleb?
Yeah, just really quickly, I think the piece around the community drug checking network, one is just to be really clear, we're just helping facilitate that. The work is clearly being done by the community-based organizations, of which there are over 8 of them. And it's really, what I think is really important about that isn't just that there's this technical network, but it's really providing on the ground insights into the drug supply, and it's being run by harm reduction organizations who have staff doing harm reduction work, and that it is part of this harm reduction continuum of care and providing, essentially trying to address information asymmetry, sorry, fancy word, but basically the fact that you know what's in your alcohol and you know what's in your cannabis, but you have no idea what you're buying off of the street, and it's leading to fatal consequences for folks. So just trying to give a little more context for that. I'm happy to share some more links so people know about that. So while this is sort of framed as around data, and yeah, I'm a data guy. I'm actually a person guy, and this is really the data and the information can be another engagement point for folks who use drugs.
Thank you, Caleb.
Thank you. Malika, did you have more comments?
No, I did not. Sorry.
Oh, no worries. All right. Anybody else want to chime in here? Please raise your hand. Michael, I don't see anything.
Oh. Yeah. Yeah, I think I will do that. I'm going to be pausing after each one when I go over it so that it gives time if any committee members want to comment, give a little more information. Because thank you, Caleb, for giving that. That was really appreciative, and Malika for I was able to correct the names and now in the Excel document and stuff. So really appreciative of that. So if there's any more committee members that want to comment any of these, or if anybody wants me to type anything because they can't click on the link, please just let me know or put it in the chat. I can do either or. The next one is the 6109 implementation. Senate Bill 6109 passed during the 2024 legislative session, had to do with child welfare and dependency cases and circumstances involving presence of high-potency synthetic opiates such as fentanyl in homes with children. This bill expands the definition of child abuse and neglect to include the presence of high-potency synthetic opiates in the home, deeming this as grounds for child removal.
And then just a reminder, we did have Dr. Vicky Ybarra from Department of Children, Youth, and Family come and share kind of a mid-implementation update for 6109 back in 2024. I know the Administrative Office of the Courts is also really heavily involved with training and technical assistance to court staff around 6109. So those are just a couple of areas where we can invite DCYF or Administrative Office of the Courts, AOC, to come and kind of share additional information about implementation, or at least how those two state agencies are supporting 6109 rollout.
All right, we have a few hands up here. Malika, go ahead.
So this just came to me, and it was actually the reporter's questions that brought this to my attention. So there were supposed to be educational materials that were developed for, I believe, both the legislature and the courts. And so I was wondering if we could get an update on what those educational materials are. It would be nice to be able to see whether or not they're accurate. So I feel like there's more places that we could get updates, because it just seems like there's not, to hear that and to know that there's a number of bills coming down the pipe that are continuing to target keeping families together and using fentanyl to do it, very much in alignment with the way that there was a distinction made between crack cocaine and cocaine back in the 80s and 90s, and it was used to disproportionately impact low-income Black and brown families. I really hope we don't repeat the same mistakes, because we are living the consequences of that generational trauma now. And so I'm hoping that we can get like a systemic update, because the update that we got from DCYF was not very thorough. There really wasn't much to say because they hadn't done much. And the fact that we're doubling down on these dysfunctional bills that are going to not create the impact that is intended is kind of concerning. And no, I didn't put it on the thingy. Sorry. Well, maybe it wasn't as clear. And when I say thingy, I mean that is a technical term. That is this tool that we're going over right now. Anyway, yeah. And I guess I wasn't specific enough.
No, that's all right. Thank you, Malika. I've actually written down review of the educational materials for you. I hope that is all right.
Yeah.
If you could say a little bit more about what you had been hoping to get from the update before, or what you're hoping to get from it when we cover it this year. I can write that in for you.
Thank you. So last year, there wasn't much update because nothing really had happened. And even though like millions of dollars were given to bureaucratic institutions, which we know does not equal immediate action. And I'm not saying that as a critique of anyone. I'm just saying that that's a fact. So my concern is that the steamroller over folks, legislative steamroller, is still going forward with a number of bills that are potentially very harmful when the things that were put in place haven't even been implemented yet in a meaningful way, and that it could distract from and take away money from stuff that we know works, like those things that we were talking about earlier. So I want to know, like, what has been accomplished, how many families have been helped. And I mean, there was a lot of education that was being done by poison control around fentanyl in children that actually debunked a lot of the stuff that was being said in the legislature, but it wasn't broadly available to folks. And so it would be great if we could get an update on what the information is that's out there, so that because this is a panel of experts, but it's also a panel of people that have expertise in a lot of different things. So it might not be all the same stuff. It would be great to be able to hear from Department of Health, poison control, like all of the most accurate and up-to-date information, so that we know what is being said to folks, and that we can also let legislators know that these are the things that they want to know. Maybe the press can, since we had them take over part of our meeting, like they could know what these things are so that they can be putting out accurate information. These are just things that I think about. Does that make sense?
Yeah, that was really helpful, and I think I captured that. Thank you so much.
All right, Amber.
I was gonna kind of go along with what Malika was saying. I love her for bringing up the crack epidemic. I'm just wondering if we could take a look at some of the legislature that was put in place during that time and just sort of overlay it with this and just see how much of the language is similar, or the implementation is similar. I feel like we're gonna probably just notice that we're doing the same thing, and I'd also like to see the actual data on, how many child deaths there have been that are proven to be from exposure to fentanyl in the home by biological parents, stuff like that. I don't think DCYF is a person to have good data on that stuff. I think that finding alternate forms of data, because DCYF is really just there to execute the legislation, right? They're there to do the footwork on what the law says that needs to be done. But I think that it's going to be a matter of having the data.
Thank you, Amber.
Yeah, no, I will
write that in.
All right, Addie.
Thanks for taking my comment. I just want to make a pitch for inviting the team that wrote the public health guidance that was required in the 6109 implementation to this meeting. Those are folks from DOH, and there's a link in the chat to that. That's a draft form. I think though they can provide information about what considerations went into that writing that guidance. And I also know that the work group that's required by the statute has been convened and is meeting now. And that's something else we could have an update from. I will also say DCYF is mandated by statute to do fatality reviews of all children who have been in their system. And we could ask the DCYF to give information from their fatality review team. They're also required to review near fatalities. And it would be interesting to hear from them about what they know about fentanyl related near fatalities, what they know prevented that from becoming a fatality. So DCYF does have data that could be helpful, but I think hearing from the DOH writing team and work group team would be really important at this point.
Thank you. Comments from the room?
Just writing that down. Thank you,
All
Addie.
right.
I don't know if folks saw that the near fatality information is supposedly not public. I don't know who you are, Terasa, so I maybe you could share more about that.
I'm from Administrative Office of the Courts,
Okay,
and I
thanks.
put a link into the fatality.
Doesn't get cut off there.
Oh, sorry about that. So I put in a link to the actual fatalities that are public. The near fatalities are not. They have I think DCYF has a wrap up of how they've gone up. I think one of the myths out there is that these deaths are due to House Bill 1227 when the fatalities actually started going up before House Bill 1227 was put into place. Um, and that is the bill where where the court system, um, the the removal standard was actually increased, but the House Bill 1227, the fatalities actually were going up before then. So that is not a direct correlation. What you will see is there are a few of the fatality reviews that where there is a child who has been affected, who has died because of fentanyl. But if you also look in the specifics regarding them, it is not something that the DCYF actually was believed were a safety threat at the time of their deaths. So if the standard of care, the standard of removal hadn't been higher, they still wouldn't have been filed on because they didn't have information that the children were unsafe.
Thank you.
I don't know if that makes any sense to you or not.
May I repeat back what I heard?
Yes, please.
Okay. So what I'm hearing you say is that, because this also goes along with things that I understand as well, is that the death rates were going up before the Keeping Families Together Act, which was the bill number that you cited, correct?
Yes.
Okay. And that the situations in which death occurred, a number of them were not situations where DCYF was even involved.
No, they were involved. If there's a fatality review that they have reviewed, near fatality and fatality, that means that DCYF was involved within the last year. So these are not like all the fatalities. These are just the ones that DCYF has been involved in the last year. Of those children who died, if you go into the details, because removal is based on safety and it has to meet the level of imminent physical harm according to keeping families together, which raise the standard of removal. However, when you go in and look at them, the state DCYF did not believe these children were unsafe. So they wouldn't have removed them, even if keeping families together
had not been implemented. So it's not a direct correlation to the fentanyl and the raising of the standard. These children, yeah.
I understand what you're saying now. Thank you for that clarification.
Okay.
Thank you. Caleb.
Just really quick, following up, when we had that conversation with Assistant Secretary Barra 6 months ago, I had mentioned at that meeting, it would be lovely if they could, actually bring treatment medications into that home. And I will say that they have followed up and have expressed interest in that. There's been conversations with them and more broadly with DSHS. And I know that the administrative office of the courts is interested in that as well. So I think really trying to think about that bill, which despite the title, seems to have a punitive impact. Maybe folks aren't familiar with how the child welfare system works or the SUD system does or doesn't work. But again, we could take that door that was opened and do something positive, which is actually bring medications in. And perhaps that's something that could be focused on maybe in the legislative process to actually mandate the offer of medications being brought into the home, which is a win-win-win for everybody involved. So there has been some interest in that. I think some of the agencies are looped into that a bit, but that is something that's sort of that resulted from this meeting and is happening in parallel. I don't know how that work is getting driven. I don't know who is connecting those dots and how that's going to become manifested. That's not something that I'm able to manage that process from the outside, but I know there's been interest expressed in that.
Thank you, Caleb. Appreciate that. I'm going to be going on to simple possession post 566. Updates on Washington State criminal legal system response to simple drug possession and how arrests and incarceration rates / trends have changed since the passage of 5536 in 2023.
So if there are any questions that you would like to have answered in the discussion or people that you want to hear from to present, unmute yourself and let us know. We'll write it in for you, or you can access it directly on SharePoint and write it in yourself.
And Nikki, I did see your chat about not having access to SharePoint. I'll take care of that today and send something to our IT team to get you access. The next one is contingency management. Oh, yeah, that's right. Anything in the chat? I know. Yeah. Right. So because of time, I'm simply just going to be going over them, the rest of them, and just saying what they are, and then you guys will have access to them. I will make sure the people who said they didn't have access to the SharePoint, I will get you access today. Well, I don't know if I'll get you access today. I will be sending the information over to IT so they can get you access as soon as possible. And once they let me know you have access, I'll let you know as well. Contingency management, an evidence-based strategy to treat substance use disorder, providing incentives to encourage behavioral change. This update could include our state investment in contingency management programs and some outcomes of these programs. Joint Legislative and Executive Committee on Behavioral Health, work group established in 2023 to identify key strategies and actions to improve access to behavioral health services. This topic could include updates on the work group's activities and potential areas of crossover with SURSAC priorities and activities. SORP and SURSAC. SORP is State Opiate and Overdose Response Plan. This topic could include regular work group updates and potential areas of crossover with SURSAC priorities and activities, as well as support in updating the state's plan currently in development. This topic could also include updates on the opiate abatement settlement spending. Presentation about OTN jail report. OTNs are funded through the federal SHMSHA State Opiate Response Grant. OTNs are a second generation hub and spoke treatment site serving people with OUD with low barrier access to MOUD. And then the last three right here are part of the SURS plan. And we do have presenters for those. If for some reason, if there's someone else you'd like to hear from other than those people, let us know, and you can write it on the side. I don't know if anybody will, but if you do, and you can also email me as well, and I can look into it, who you'd like to present on it. Training for caregivers is RCW 71.24.522, established as a result of SURSAC's recommendations in past and 5536, and required HCA in consultation with DCUIF to develop and training for parents of adolescents and transition age youth with substance disorder on evidence-based practices for caring and supporting loved ones with SUD. And the last two, the diversion data integration platform established as a result of the SURSAC's recommendations in past and 5536 requires HCA to implement a data integration platform as a statewide common database to track diversion efforts for recovery navigator, lead, and arrest and jail alternative programs. SUD prevalence data reporting passed in 5536 requires HCA to provide regular assessments of the prevalence of substance use disorder and the interaction of people with SUDs with service providers, nonprofit service providers, first responders, health facilities, and law enforcement agencies. And updates on SEDISA and the Safe Supply Work Group will be provided after the conclusion of the legislative session. This session ends on April 27th, 2025. Yeah.
Let's take Amber's question and any other comments from committee members.
Yeah, we've got Amber.
Hello. I was just gonna say that a good person to reach out to might be Laura Okoloko. She teaches the craft program for the educating caregivers of children with SUD. She's an expert. It's the community reinforcement and family training model. It's evidence-based.
Amber, could you put her name in the chat if you don't mind?
Sure. I'll even try to find her website, maybe.
Okay, that'd be great. Yeah.
Thanks, Amber.
Thank you, Amber.
Okay, I don't see any other questions. So we move on to the next agenda item.
Well, we're kind of out of time. I had a really good conversation about some of those items on the Excel spreadsheet. So I think what we'll do is please contact Kelly if you're unable to access the Excel document and you're a committee member. We'll make sure that we contact IT and figure out, what next steps are necessary and try to get everyone on the committee access as soon as possible. For those that are able to access the document, please take a look at it, add any comments or notes or suggestions for each of those topical areas. We ran out of time to review the next month agenda, so we can just do that through email. We'll have Kelly can send out a draft in the next couple of weeks and identify what at least which areas we know are already scheduled. I think there's probably going to be a recovery navigator program highlight, and then whatever else ones that have been already identified, but we'll get that out to the committee ASAP. And then also hopefully by next meeting, we'll have a finalized kind of 2025 agenda planning document, which indicates like which of these topical areas we have slated for each of the months that we have. 2 hours goes by so fast. I feel like there was great presentations, great updates today from Senator Dinger and Representative Davis, and a really helpful conversation around 6109 and the potential implications from that legislation as it continues to be implemented. And just really appreciate everyone showing up and being present and asking questions, providing feedback, making comments. It really makes for a more robust meeting and constructive dialogue, and just really appreciate that today, especially on a Monday after a holiday week, and some people being able to take time off from that. So with that, I don't know if anybody in the committee has any final comments, or Blake or Kelly or anybody else.
I think we're good.
Otherwise, we're going to include a lot of the links that were shared today and some of the information that people were trying to put in the chat but weren't able to. We'll make sure those are included in the notes and get that out shortly, as well as a YouTube link to the recording from today. And just really appreciate everyone's time, and we'll see you in a month. Thanks so much.